Good day, and thank you for the invitation to present about renovascular hypertension in children and having a little emphasis on interventional radiology. I have no relevant financial conflicts of interest to disclose. What I'd like to do today is just discuss some of the lessons that we've learned over the past 25 years in dealing with children with renovascular hypertension, and we'll focus on how children present, the syndromes that are associated with renovascular hypertension in children, evaluation in children, conservative management, interventional management, and surgical management. So I thought I'd put up a little bit of physiology as we start to show you the pathway that's affected when you get narrowing of the arteries just before going into the kidney, and you activate this pathway called the Reninangiotensinaldosterone system that essentially is in place to bring the blood pressure up when it's low. However, when you have narrowing of, say, a renal artery, the system gets activated and results in effects that narrow the vessels and also results in salt and water retention. This leads to hypertension. And so hypertension in children is found mainly at routine screening and well-child visits. Most often hypertension in children is silent. It can also be seen after a surgical procedure, and we've seen a number of such children. It may be a feature of the primary disease. We've occasionally seen children who've had profound sodium decrease in their electrolytes and a low potassium, and then some of the children do present with hypertensive urgency and stage 2 hypertension, which is a very high blood pressure. But as you can see, the headache is really non-specific. Less commonly, as you present with seizures or neurological changes or GI bleeds, or sometimes with cardiac manifestations, especially in the little children, but that's a minority of children. So the causes of inflow abnormalities to the renal artery can be narrowing, which is what we're talking about today. It can sometimes be inflammatory, and we can find the manifestations of an inflammatory disease. Occasionally combined with something called Metaotic syndrome, or co-optation of the aorta, which is higher up. And then we can see it with renal tissue problems and with tumors. So there are a number of genetic syndromes associated with renovascular hypertension, neurofibromatosis being one of them, FMD being another. Yeah, we know there are multiple genes, as I'm sure you're aware. There's something called Alagille syndromes, Williams syndrome, tuberous sclerosis, and idiopathic arterial calcification. Those are the ones that we see most often. There are others, and I've listed those on the right-hand side, and I'm sure that over time we will find other genetic causes. Now, pediatric FMD is a little different to adult FMD. Stenosis is often tubular and unifocal. The renal artery is most often involved, but we do see other arteries within the abdomen involved and other arteries within the body, but not nearly as commonly as in adults, and certainly not involving the coronary arteries very often. There's no large gender disparity, and there's less likelihood of having aneurysms, although we see them, and far less likely, as far as we know, of having dissections. So I wanted to tell you about a kid that went for a routine physical. Blood pressure was shown on 3 measurements to be 170, 105, was referred straight through. He had a normal metabolic panel. Echocardiogram showed he had a large left ventricle, And the ultrasound with Doppler really didn't help. He had a DMSA scan, which showed that he indeed did not have anything like a scar in his kidneys. And on angiography, had this focal narrowing, which responded very well to balloon angioplasty. This is the common way of seeing him. Here's another child who we saw when she was 4. Sorry about that. We saw when she was 4, and she had a left facial nerve palsy. She was given steroids by the ear, nose, and throat doctor, an antiviral agent, and went for a sedated MRI to see what was going on with the nerve that is involved in facial nerve palsy, which is the 7th nerve, cranial nerve. And her blood pressure was elevated to 210/120 millimeters of mercury. She had agitated behavior but normal renal function. And as you can see in the right-hand panels, had a very tight, long stenosis, which was not amenable to balloon dilatation. And she has required surgical repair. She's also had surgical repair to other intra-abdominal aortic arteries. From the pedigree that's shown, the interesting fact on this child is that there's autosomal dominant transmission, and her mother and grandmother also have fibromuscular dysplasia. So how do we evaluate renovascular hypertension in children? We get a history, we find out about headache and the other symptoms. We then do a physical exam and look for a syndrome. We look for bruits, which are usually not present. Any focal neurological signs may also be useful. And then we start with a lab evaluation and get a CBC and metabolic panel. And we're particularly looking at the potassium and the sodium, as well as the bicarb and creatinine, to see if there's normal kidney function. But as I mentioned in the physiology, that potassium and sodium can go down with the activation of the Reninangiotensin system, so we pay particular attention to those two electrolytes. Above, you'll see that we don't wait for everything to come back. We start management of the hypertension early on, and we'll come to that. We also get imaging, including echocardiogram, a renal bladder ultrasound with Doppler, possibly an MRI or an MRA, and a CTA. However, angiography is still definitive treatment. So how do we actually control the blood pressure in these children? Well, we use the general principles of a low sodium diet, and if there's stage 2 hypertension or stage 1 with, say, a thickened heart muscle, we'll restrict activity, and there'll be no competitive activity until the blood pressure is controlled. In the pre-imaging and before knowing what's going on, we'll use something called calcium channel blockers like amlodipine, beta blockers like atenolol, or peripheral alpha blockers such as Cardura. However, once the hypertension is established, one can consider blocking that pathway that I showed you using an angiotensin inhibitor or an angiotensin receptor blocker. So what about imaging of the renal arteries in children? Well, we've shown that the sensitivity of the renal ultrasound is not very good. So you can see 28%. A little bit better with MRA and fairly good with CTA, but certainly not as good as angiography, which we used as our gold standard. So what's the use of the ultrasound and the Doppler? Well, when the Doppler is positive, then it's pretty specific. But I really use the ultrasound to look at for scarring, and here we have a scar over there, or for a mass that may be pressing on or actually causing the hypertension, such as a neuroblastoma or a pheo or adrenal mass, such as we're being shown over here. So it's very useful to do ultrasonography with Doppler. However, it's not the point where we would stop and say, if it's negative, we're not going to do anything. So what about imaging of renal arteries? Well, we like CTA. We have a low radiation dose technique, and you have to be careful how you actually time the actual CTA. But it has a pretty high sensitivity and specificity at the main renal artery, while we have managed to cut back on the amount of radiation. However, its sensitivity as you go into second, third, and obviously the fourth order branches is pretty low. So we see CTA as offering a value in low to medium risk patients and as a screening tool and pre-procedure planning modality for the high-risk patient. What about the pattern of FMD distribution in children? Well, as we've shown and others, that the lesions are not just in the main renal artery and the second renal artery, which are amenable to angiography, but they may be in the third or fourth order, very difficult to get to, and not manageable by angioplasty or by direct surgery to the vessels themselves. The other important thing about looking at these children is to do angiography. So we've had a great deal of success with the angiography, especially more recently where we have been using cutting balloon angiography. However, where the lesion's over the 10 millimeters in length, so a centimeter, or there's deep disease, or there's bilateral disease, success rate has not been as high. Now, renal artery stenosis might occur with something called Metaotic syndrome, and this is uncommon. There are many etiologies which I have not put up here, but it can be associated with an FMD-like lesion with neurofibromatosis. You do need to treat the hypertension. You may need to initially treat the metaotic stenosis. We try to be conservative and allow the children to grow, and only treat pre-pubertally when necessary. We involve an entire team, which includes the surgeons, interventional radiologists, the nephrologists, and others as needed. And we try not to do too much stenting of the aorta. We have had children who have come with stents in their aortas, and the risk is that you cover a important artery with the stent and have consequences related to that. So with balloon angioplasty, you use different sizes of balloons. It's chosen by measuring the adjacent non-stenotic region, and for resistant stenosis, as I've said, we've used this cutting balloon. The balloon is downsized, and then after that a conventional balloon is used. There is a risk of transluminal perforation, for which direct pressure can be applied by a balloon, or a covered stent can be placed. And this would be one of the few times in which we would actually use a stent. This thing has a life of its own. So in terms of stents to treat renal artery stenosis in children, we reserve them for select instances. We avoid them wherever possible. However, they can be used if you want to seal a renal artery, as I've said, after dissection, or as a temporizing measure before surgery. Use them after blunt trauma. Perhaps use them in severe or recurrent lesions in children, and in lesions that show a lot of elastic recoil or stenosis after conventional cutting balloon angioplasty. Again, we've not had to do those except in kidney salvage instances. So surgery has a real place in the management of renovascular hypertension in children. This is a slide just to show some of the data related to that. And as you can see that primary vasculation and primary nephrectomies are pretty good at both curing and improving the hypertension. They're not absolute, however we do work together closely with our surgeons. So when we do find renovascular hypertension in children, we do imaging of the head and neck. There's very little literature on FMD in childhood stroke, and this was Dr. Curtin's publication now 8 years ago, where he put together the cases of children who presented with stroke who may have had fibromuscular dysplasia. But there's no good literature on if you present with renal artery stenosis and FMD, what's your risk of having a stroke, and how much vascular disease you're going to find. Certainly not like there is in adults, where this is now very well known. However, we still do an MRA of the head and neck vessels in children who present with renal artery stenosis, and have found one child who had arterial tortuosity, but that is all. So just some updates and some thoughts, and thank you very much for your attention.